Good evening, everyone. I welcome you all to the Tuesday webinar from Yashoda Group of Hospitals. We try to bring some interesting, thought-provoking, but relevant topics to discuss and to bring on the table. Today, as usual, to continue our the way we are doing things today, we are going to discuss yet another controversial but very important topic. Do we need a booster dose of COVID vaccine now? As we all know, in the last few months, the number of COVID cases has increased throughout the country of India, and we have listened to few deaths here and there. With all those things going on, most of our let it the treating people or people who are at risk are in a controversial state or in a dilemma that they should take COVID vaccine or not, or shall we advise COVID vaccine to the people who are at risk? So this is a controversy that we are trying to unfold today. So to discuss this topic, we have Padmasri, Dr. Raman Gangakhedkar. He is an expert panelist today, who is the former chief of ICMR, which is a part of WHO when it comes to COVID. So we believe that he will be the best person to discuss on this topic today. Thank you very much, sir, for accepting our invitation. To have an idea what is the current status, what are the different vaccines available, and what are different types of immunity one person can get post-COVID or post-immunization. To discuss all those things, we have Dr. Monalisa. She is our ID specialist. She has done her MD and DM both from All India Institute of Medical Sciences, Delhi. She will be taking through a small presentation to have an idea what we are thinking of and how to go forward. And I will request each and every delegates or the attendees to post their questions in the Q&A section. And we will take all of those questions at the end of the discussion. And to start with, I will request Dr. Monalisa to present the whole thing. Over to you, Dr. Monalisa.
Thank you, Mr. Sir, for the kind introduction. Today, we shall be discussing a very relevant topic of the current situations. Like whether do we need a booster additional dose of the COVID vaccine or not. So to go to the topic, prior to going to the topic proper, I would like to brief about the current things that are available. We shall be going through the discussion under the following heads, like seeing the current epidemiology of the COVID, the vaccines available, the vaccine efficacy, the nasal vaccine that is there, the WHO recommendations regarding the use of a need of a booster vaccine, the bivalent vaccine that has come a few days back, and the take-home points. The whole world has been tackling the problem of the coronavirus since 2020, and the war isn't over yet. Like with the new variants coming every few months and new mutations. So we need, the war isn't over yet. And this is the current scenario. Like in the last week, there were about 58,000 confirmed cases across the world, with about 372 deaths occurring in the last week all across the world. And this is the scenario in India where the total number of cases as of today, the screenshot has been taken today from the Minister of Health and Family Welfare site. There were 3,300 cases detected yesterday with about 10 deaths. And about 2,180 new vaccinations have been done, with the total vaccination being about 22,066 lakh doses. So what is the basic need of vaccines? We all are aware of it, but to begin with, the vaccines, the most importantly, they provide, they prevent against the severe disease and also provide a herd immunity. A herd immunity is one which develops when most of the people in a community are vaccinated against a disease, and it prevents the ability of the pathogen, and its spread is limited. And this is called the herd immunity, or the indirect or the population immunity. And when many of the people have immunity, it also indirectly prevents the infection, or protects the people who are not vaccinated, like the very young babies, the infants, and those with the immunocompromised status who cannot take the vaccines. The vaccines mostly decrease the risk of infection by training the immune system to recognize and fight against the pathogens when they come across it naturally. And also sometimes the booster dose is required when the immunity starts to wane off after a few months of the primary vaccine. Or when there are like in the several seasons, there are like mutant viruses and new variants coming up, there are new needs for the booster vaccines to cover for them. When a vaccine is administered, it activates the adaptive T immune response, causing the antibody production from the B cells, which prevents the virus from entering the cells, as well as activates the T cells, which kills the infected viruses by thus preventing the viral replication. Several vaccine platforms are available, like the virus vaccine, which uses the virus in an inactivated form, the viral vector vaccine, which uses the genetically engineered viruses, corona proteins, the nucleic acid vaccines, and the protein-based vaccines. Coming to the definitions of vaccine efficacy, it refers to how the vaccine performs under ideal conditions, like under the clinical control trials, but there are several factors which affect in the field, like, and that is referred to as a vaccine effectiveness, which refers how the vaccine performs in the wider populations when being used. This is the slide showing the various platforms that we discussed about. The vaccines which use these platforms, like the nucleic acid mRNA vaccines, include the Pfizer, BioNTech, and the Moderna vaccine. The protein-based vaccine being the Sanofi and the Novavax. The viral vector vaccines, and the inactivated viral vaccines. There was a rapid accelerated vaccine development timeline for the COVID vaccine. Normally, when a vaccine development occurs, all the phases are carried out one after one, like in the sequentially. But in the case of COVID, there was an accelerated vaccine development timeline where all the stages were taken across parallelly. All the usual safety and efficacy monitoring mechanisms were there in place, and they were taken place. And also the adverse event surveillance, safety data monitoring, and long-term follow-up were done. The phase 4 post-marketing surveillance is the most important to see for the side effects, and is being carried out. There are several factors which affect the COVID vaccine effectiveness positively as well as adversely. The demographic factors which have a positive impact on the COVID vaccine effectiveness include high levels of vaccine uptake, high levels of herd immunity, and the host factors like a previous infection are the positive factors, whereas the ones which have a negative impact on the vaccine effectiveness include the host factors like old age, presence of immunocompromised status, underlying other comorbidities, high levels of circulating virus in the demography in the population, and living in close proximity with each other peoples, and limited access to the vaccines, as well as the viral factors like the antigenic mismatch with the vaccine and increased transmissibility. These factors cause a negative impact on the vaccine effectiveness. The immune correlates of the vaccine protection can be measured by the antibody response, which is a surrogate marker, and the other correlates may differ depending upon the endpoint used, like the protection from infection, disease, and the severe disease. The most easy way to assess the response is an antibody response, but it is only a surrogate marker. As it has been seen that the vaccine efficacy wanes off over the time, like with the mRNA vaccines, which had efficacy about 94.5% at 2 months, the vaccine efficacy decreased to about 80% and 66% respectively at a 7-month period. The other vaccines like the AstraZeneca Jadox vaccine also had a decreased efficacy over the passage of time. Similar was with the Covaxin as well. Coming to the nasal vaccine, the nasal vaccine, or the need for the nasal vaccine is that the most of these viruses replicate at the mucosal sites, and it is very crucial to for the development strategies for the neutralizing antibodies to be present against this virus at these mucosal sites. The mucosal vaccines help in development of a local antibody response, and It involves administration of the vaccines at one or more mucosal sites. It involves the delivery of the antigens into the nasal associated lymphoid tissue, the NALT, and the most commonly used route is the nasal or the oral. The response is measured by the antibody, that is the secretory IgA, and it also parallelly increases the activates the local cell mediated immune response, as well as and these effectors have been shown to clear the virus from the local site. Thus, it helps in early control of the infection. Also, it helps in control of the non-invasive infections at the mucosal sites. It decreases the need for an injection and also has a widespread response. But the limitations being in practice, it is difficult to induce the IgA response, and the antigen instability is also seen at the mucosal sites. But the advantages outweighs the limitations. Recent studies have also shown that this intranasal vaccine can prevent replication at the local site as well. And it also induces a higher level of spike-specific neutralizing antibodies in the animal models as compared to the intramuscular vaccines. There are several types of intranasal vaccines that are under development, like the virus vector vaccines, the protein subunit vaccines, and the various study results show that they prevent the lung inflammation and pathology. They clear infections in the vital organs also, and the undetectable viral RNA in the upper and lower respiratory tracts has been demonstrated, and they provide long-term immunity as well. And they also prevent the shedding, viral shedding from the mucosa, and prevents the transmission as well. These are the various intranasal COVID vaccines that are under the various trials across the world, including the Chadox and the AdCovid. The intranasal vaccine that got the approval in India was the Incovac, manufactured by the Bharat Biotech, and it was approved in December. It is approved for the use in 18 years above age group, and it is administered as two intranasal doses at day 0 and day 28. It consists of the replication deficient ChAd vector expressing the spike protein. As we have discussed, there are the several advantages, like it is better in activating the local immune system and the nasal mucosa. It is non-invasive, needle-free. There is a ease of administration, and also decrease in the risks of needle-associated risks and high compliance. And the manufacturing is also scalable to meet the global demand. Like in correspondence in the NEJM showed that the risk of the BA5, the currently circulating variant infection, the use of the previous vaccines, like the initial Omicron subvariants, BA1 and BA2, that have progressively been replaced by the BA.5, and there is a greater transmissibility and partial evasion of the immunity allotted by the BA1 and BA.2. So the protection that the vaccines that could have given, or like against the infection by the BA1, that is not protective against the subvariant BA5. Another study done about the COVID vaccine protection among the children and adolescents in Qatar showed that the vaccination in children was associated with a lower protective rate, and there was a waning of the protection against the Omicron. And in the adolescents, it was associated with a stronger and durable protection, maybe due to the larger antigen dose in the adolescents. The immunity, the immune response wanes off over the time as after the vaccine. So there is a need for the booster vaccine, and this reduced protection can occur, can lead to increased hospitalization as well as severe disease. The use of both homologous as well as heterologous booster doses can increase the immunity, reduce the hospitalization, as well as provide protection against the variants of concern. There are several limitations for the booster studies, which includes like the RCTs are the ideal studies which should be done, but they are not feasible. The exposure to the various variants cannot be measured objectively, and the vaccinated individuals, they do not tend to take the test more often, and The cell-mediated immunity is infrequently studied, and the neutralizing antibodies are only a surrogate marker. And we are not able to predict the future variants that would come, unlike the influenza. And so these are the limitations which limit the use of the booster. The various guidelines suggest that the immunocompromised individuals should be taking a second booster, that is after the additional dose. And the immunocompromised people include the one with the solid organ or hematological malignancies, the solid organ recipients, or those on immunosuppressive therapy, those on after the hematological hematopoietic stem cell transplant, those with primary or secondary immunodeficiency conditions, advanced or untreated HIV, and those on active treatment with high dose steroids and other chemotherapeutic agents. They all come under the immunocompromised population who require an additional second booster dose. Coming to the recommendations by the Strategic Advisory Group of Experts on Immunization, which is recommended by the WHO. They had a meeting from March 20th to 23rd and came up with a roadmap for the COVID-19 vaccine booster status. In that roadmap, they have prioritized protecting the population at the greatest risk of death and severe disease, and it focuses on maintaining the resilient health systems. The roadmap also considers the individuals at a lower risk, like those healthy children and adolescents. They may be given vaccine. The decision whether to give them or the vaccine or not should be based on the several factors according to the different countries. The revised roadmap re-emphasizes on the importance of vaccinating the individuals who are at a higher risk of disease, of severe disease, and they have categorized the population into the high risk, medium, and the low risk populations. And these categorization is based on the risk of severe disease and death, and consideration of the vaccine performance in these populations, and the cost effectiveness, programmatic factors, and the community acceptance. These are the criteria that had been considered while categorizing the people into the three categories, like the high risk, the medium, and the low risk. The high priority group includes the older individuals, the younger adults with significant comorbidities like diabetes and heart disease, people with immunocompromising conditions like people living with HIV, the transplant recipients, including the children of 6 months and older who have the immunocompromising conditions, pregnant population, and the frontline healthcare workers. They are the high priority group, and the recommendations for this group include an additional booster of either 6 or 12 months after the last dose. And the time frame, like whether it is to be 6 months or 12 months, it depends upon the factors such as the age and the immunocompromising conditions. And these recommendations are time limited and are according to the current epidemiological scenario only. And so the additional booster recommendations should not be seen as like every continued annual vaccine boosters need to be taken. Coming to the medium priority group, it includes the healthy individuals who are under the age of 50 to 60 without comorbidities, and the children or adolescents with comorbidities. The SAGE recommends a primary series and a first booster for the medium priority group. Although the additional boosters are safe in this group, the SAGE group does not recommend routinely additional booster in this group, there is low public health returns. Coming to the low priority group, it includes the healthy children and adolescents from healthy children and adolescents within the age group of 6 months to 17 years. And a primary and a booster doses are safe and effective in these children, but whether to administer that or not depends upon the burden of the disease and the various factors in the country, like the disease burden, the cost effectiveness, and the other programmatic priorities. The healthy children and adolescents, the more priorities would be given in administering the other traditional essential vaccines, like the rotavirus, measles, and pneumococcal vaccines, which have a more protective value rather than the COVID. And in the children with the immunocompromising conditions and the comorbidities, they're included in the high risk group as they have the risk of developing severe disease. So they should be given the additional dose. Coming to the pregnant females, they are also included in the high risk group, and vaccinating the guidelines suggest that they should be given an additional dose if the last dose was given more than 6 months ago. and as it protects both the mother and the fetus by preventing the severe disease in the fetus as well and the infant as well. So the key recommendations include administering the additional booster doses beyond the first booster dose for the high priority groups, including the frontline health workers 12 months after the previous booster dose. Additional booster doses are not routinely recommended for the medium risk group, and the administration of booster dose for during pregnancy if the last dose was given more than 6 months earlier, and considering the primary series and booster for healthy children and adolescents in the context of the country. And the countries which already have a policy for the additional booster doses should assess the evolving need based on the disease burden, cost effectiveness, and the other opportunity costs. The SAGE also updated the recommendations about the bivalent COVID vaccines, and they now recommend that the country should be using the BA.5 bivalent mRNA vaccine as the primary series. The FDA came up with the notification a couple of weeks earlier that the FDA authorizes the changes to simplify the use of the bivalent mRNA vaccines. It states that the US FDA amended the emergency EUA for the Moderna and Pfizer BioNTech bivalent mRNA vaccines for most of the individuals. It includes authorizing the use of the current available bivalent vaccines, the original and the Omicron BA.4 and 0.5 strains, to be used for all individuals 6 months old age and older, including for the additional dose for certain populations. And the monovalent Moderna and Pfizer BioNTech vaccines are no longer authorized for the use in the US. These are the various guidelines that they have come up with. Most individuals who have already received the single dose who have not been vaccinated should be vaccinated with the bivalent vaccine. Those who have already received a single dose of the bivalent vaccine should not go for another dose. The individuals more than 65 years of age who have received a single dose of the bivalent vaccine may receive an additional dose at least 4 months after the first dose. And those who have an immunocompromising condition may receive a single additional dose of the bivalent vaccine at least 2 months, followed by a second dose. Most of the unvaccinated individuals may receive a single dose of the bivalent vaccine rather than multiple doses of the original monovalent vaccine. The director of the FDA said that the evidence now shows that most of the US population of 5 years or older has the antibodies against the SARS-CoV-2, and either by vaccination or infection, and this can serve as a foundation for the protection that can be offered by the bivalent vaccines. The COVID-19 still continues to be a real risk for many people, and they encourage the use of staying updated with the current vaccination schedule and including the bivalent vaccine, COVID-19 vaccine, in the routine vaccination. Coming to the last part, after this presentation, we came to know that the vaccine efficacy is definitely wanes off with time and is more so reduced in the immunocompromised population, and the antibody levels after most of the vaccines wanes off after 6 months across all populations. The intranasal vaccines help in the development of a local immunity and may perform better than the intramuscular vaccines. And the COVID-19 has definitely opened up a whole new world of vaccine technologies.
Yeah, thank you, Dr. Monalisa. I think it was a nice presentation touching up most important things when it comes to different vaccine types of immunity and what is the current status and what all the guidelines suggest at this point of time. So to start some discussion, Raman sir, do you believe the waves, what we have seen, during the severe pandemic, what we have seen, first wave, second wave, few places they have seen third, fourth waves also. Do you believe we can have similar kind of waves in future?
See, there are some statements which I would like make, but they are very personal. No, please don't ascribe it to any institution. No, the presence of waves, once the infection becomes milder, depends on the number of tests that you will do. This is a convergent evolution. Now, in convergent evolution, there are certain factors which we have to remember. Now, if you actually look at what has happened in Omicron and look at the past, no, you will find that earlier, every 4 to 6 months, there used to be a different variant which used to predominate, no, pre-Omicron. Now, when it comes to Omicron, now you are 16 months plus after the first report of Omicron variant. All the variants that you are seeing, they are belonging to the same Omicron family, right? Now, to put it crudely, why are we seeing variants? Because even within the same family, there are siblings of Omicron which are trying to acquire the skills of infecting human beings far faster compared to others who are competing within the family. And when I say that, it also means that if you look at any population, uh, at given point in time, you will find it's a soup of different kinds of variants that exist within the same family. Now you could have, no, now today you are talking of XBB, yesterday you were talking of some different variants, but they belong to the same family. They're trying to evolve one way or the other. But in evolution, the virus also remembers that if it increases the severity, that's a death sentence for the virus. No? That variant cannot grow. It's something akin to Ebola. No? Ebola is good at killing people. Nipah is good at killing people. No? And therefore, that limits the scope of its survival. And therefore, what you are seeing is a convergent evolution where multiple variants could be existent in any geographic area. So the more you will test, the more will be the number. And there is one we must remember that when you have a milder variant, which is trying to compete for its predominance by increasing transmission efficiency, you must also remember that such variants will prevail only for a short period of time because they don't want to do any harm. And for Omicron, what is most important to remember? We should never count daily new infections. No, because they become irrelevant for public health purposes. You would like to look for a variant which has increased severe disease, which increases hospitalization, which increases death. So to me, whether waves will occur, yes, they will occur. But where would you note them? Where you will find that the health-seeking behavior is good among the population. Those who come forward to go for testing, even in milder infections per se, that can only happen more often than not in developed countries. Because there, if you want to avail the test, you have to go to the public hospitals where the insuring agency will provide you access to healthcare. But in country like India, where even when we were peaking with Omicron, people refuse to get tested. And the result is you will find even today, people don't come forward to test. So whether those waves will occur, the waves are bound because these are escape mutants. They continue to be milder. More often than not, you will not detect it unless you will perhaps test the population as much. So basically, waves will occur, but you will never notice them because they will not get admitted in the hospitals. So how do I know? So these numbers are irrelevant. New infections numbers are irrelevant as of now when it comes on for public health purposes. For research purposes, you should worry because you want to keep this virus under surveillance. So therefore, for the government or research organizations, they have to look at those new numbers, whether the clusters that are occurring are different, to try to find out whether the virus is mutating in a manner which is unpredictable and can lead to increase in the risk of hospitalization or death.
Do you believe then, sir, it is kind of endemic now? It's or like how to put forward this, sir?
I wouldn't call it as endemic for one reason. If you cannot detect the waves because people are not coming forward, I don't think we have evidence to say that it has become endemic. There would be rise in numbers, if you test, but those may not make difference in terms of provision of care. So if you want to call it as endemic just because they don't want to, the patients are not increasing in the hospitals, then you may do so. But the risk will be that one has to understand that you are equating endemicity to severity of disease. But if endemicity is to be thought of classically, the way we define, it is low level of new infections that tend to occur throughout. No? That may not be true. So I still believe that the virus has not become endemic, but it is moving towards endemicity. We have to just wait. And there is ample of evidence, especially in the developed world, that a new and newer variant tends to predominate in those countries because they have to access the test through a reportable system. Whereas in our country now we have even permitted home testing kits. So how would you know how many are actually infected? And to my mind, if I was to give a very blunt answer, I don't think even the current variant can be called as variant of interest. It has gone lesser and therefore it is variant under monitoring, not even interest.
Then, nicely narrated, sir. Actually, why we are getting this kind of sprouts, sir? Actually, now if you see, there is a sudden rise in the number of cases over the last maybe 3 or 4 months, and good number of deaths happening. We know that most of the cases we are presenting into our hospital, they are having multiple comorbidities. They are immunocompromised people, old people, COPD, and all those things. And sometimes we are incidentally finding. Actually, we are doing a CT scan for some other reason. We are finding some GGOs which become famous during our COVID time. So we are finding something. We are sending a COVID coming out to be positive. And I'm not very sure, 1 or 2 cases where we felt that maybe the COVID is the primary reason why they had significant hypoxia and all. There was no death at this point of time with so many admissions where COVID came out to be positive. Like why this kind of surges are coming, sir, in between? If like Omicron is still there throughout from that, let's say, last booster or whatever the second dose of COVID vaccine, people have taken a year back or more than that, and we believe that the duration of COVID-related immunity or vaccine-related immunity stays for 6 months at max.
See, I would put it very simply. I don't want to add to controversy, but when we say people die, people are still dying of with this variant. Please remember, when it's a highly transmissible airborne infection, the likelihood that that person may have acquired it when the person got admitted in the hospital also increases as a concurrent infection. So everybody who has come out as positive, does it necessarily mean that the person has COVID infection which is causing death? I have no idea. Nobody has that idea because those case definitions related to deaths that occur because of COVID, and how do you dissect the infection that the person may have acquired because he is coming into a sick environment. Sick is in quotes. That there are many people who have different infections or different diseases. He is coming there. You have high crowding that tends to occur in the hospitals when they come. So we have no clue as of now. To my mind, one must believe if the major cause of death was due to pneumonitis that led to deaths during the Delta wave, there is still no evidence that the entry of the virus is occurring differently than what was reported during Omicron, and it doesn't lead to development of pneumonia as often as we had almost seen. Almost everybody who was vulnerable was getting pneumonitis in Delta. And that's why we had high mortality, and presentation used to be RDS at the beginning. But that doesn't happen now.
Yeah,
So
correct, sir.
therefore, there could be, but I cannot talk it with confidence or in public, because do we have that kind of data? We don't have that data. We made efforts to actually develop a case definition for deaths that occur among patients who are RT-PCR positive. At present, no. This is a milder variant. We have no idea. And therefore, I would not be very much concerned, knowing fully well as of now, that the transmission efficiency or even the R0 value is extremely high. If you look at the reported value even from China earlier, it was R0 was close to about 16 to 18. But even that 16 to 18 was questionable. It is an underestimate, mainly because when you do that, you have to remember a larger proportion when it comes to mild illnesses would continue to remain untested because they just don't go. This is milder infection. So the R0 value must have been far higher than what we have imagined. And now you are talking in terms of XBB. For XBB, it must be worse. So to me, it's an issue which is researchable rather than one where you can conclude. But as I said, I don't want to confuse because it doesn't make sense when you don't have evidence. They become speculative kind of statements. But I still believe the speculation is closer to the truth.
Actually, like Salal, after this surge of cases throughout India, a lot of people have called, and even the patient relatives also has been asking, and more so with the doctors who are practicing. They have a doubt that is we all know in the this healthcare professional we took two doses of COVID vaccine, then we took a precautionary dose also, maybe around 6 months or 1 year after the second dose, and that dose we have taken around 1.5 or maybe around more than 1.5 year now. So shall we take a booster dose? That is one question. At least healthcare professional apart from the high risk group. And second thing, with all those questionable things are coming up with all those side effects and all those things with vaccines. People have different papers have come up like with vaccine they have developed this, that, even thromboembolic events are there now linking with vaccines. Do you believe we should think of giving vaccines after the precautionary dose to take a booster dose? Is now the stage this guidelines also came that after the precautionary, because we will be coming into the high priority group where we are supposed to take one more booster dose. Do you strongly believe, sir, we should go for a booster dose? At least the healthcare professional high risk group?
Now, I must make one disclaimer. I'm not part of that COVID vaccine related group. I'm part of the origin of COVID for which China and the US are fighting. Therefore, I have full rights to critique what WHO is saying through SAGE. To my mind, some of those findings, some of those conclusions have to be taken with a pinch of salt. No, as Madam, while during her presentation said, they are looking at neutralizing antibody titers at 6 months. Majority of the studies are at 6 months. And then we say it is waning. It is bound to wane. If you are not exposed to an organism, why should the neutralizing antibodies increase? There is no reason to believe that they will increase because they become redundant. That's natural immunology. But I think what is most important for us to remember that for whatever For whatever decisions that we have made for evidences, despite the fact that it is 2 years into vaccine era, COVID vaccine era, we still don't have robust data. Similarly, about T cells. Now, if you disbelieve T cells, that they will not remain as a effective strategy, there could be that there is a possibility that it may not work as much. But I don't believe that T cell response will not kick off in first 2 to 3 days time and control this infection, because you have to look at one issue little more critically. I'm sorry, I might confuse you, but if you look at the vaccines that we had manufactured, all of them were on Wuhan virus until the time bivalent vaccine. What is a consistent feature of these vaccines? They did not protect against infection because they were escape mutants which were coming. But when it comes to the protection against severe disease has been consistently seen, even if you actually received Wuhan virus vaccine, which is far different. No, if you look at the sequences of Wuhan virus and compare that today with Omicron, it's very difficult to believe that it continues to work, because one of the factors is we do not know what causes severe disease. If you look at the sequences that tend to come out, we are associating the spike protein related issues more commonly in terms of entry of infection, believing that the more the viral load it is, perhaps the risk of transmission, risk of severe disease is likely to increase. But even there, we don't have sufficient proof. So to my mind, thinking of fourth dose is a difficult situation. If I was to put it as my personal view, I would never recommend a fourth dose, excepting for those who may be highly morbid and perhaps more vulnerable. To me, you have to trust the T cell system. You have to trust that system can also get exhausted as much. If I keep on pushing one vaccine after another vaccine, that's also not a good strategy per se. So to me, precautionary dosages that you have taken as the third dose is good enough. Could there be a room that those who are highly morbid would require a fourth dose? It will depend on how you understand this disease now. Because I have always questioned one wisdom that we call COVID. We don't have a good definition of COVID. No, basically, the moment the fever is gone, fever is the mainstay. No, fever is gone. No, we say COVID is cured, or we have been able to get rid of COVID. The reality of life is, when you think of long COVID, there are evidences that are emerging which say that the virus is still there in different compartments. That is why you are getting long COVID. Don't know when does the COVID actually end. You think of it as a possibility that long COVID is symptomatic COVID plus long COVID that tends to occur. Then we don't have enough of evidence to say what does it prevent. Because if what they are doing is, we are talking today of deaths that occur in the immediate symptomatic period of 8 to 10 days, right? Then we are excluding those deaths that could occur because of hypercoagulability, some thrombotic events that may occur subsequently. If they are occurring due to COVID, then there could be a different interpretation that may come. But I still believe that provision of fourth dose may not be required. Now, that's a tough decision to take, because whether we like or not, No, the vaccine lobby will give you some kind of which could be used for interpretations. No? But the reality is, I don't think, if you look at even vaccines, no, at least Pfizer has agreed, Moderna has agreed to some extent in terms of the responses that you get to bivalent vaccines. No? What it classically shows is, even if you give a bivalent vaccine, the neutralizing antibodies that tend to rise consistently and well enough are against the Wuhan virus, against alpha, beta, delta that you talk about, more than what would happen to Omicron. The reason is perhaps this is better explainable by a phenomena which is called as Hoskin's effect or original antigenic sin. And therefore, if original antigenic sin can be kicked off, it essentially means that no matter how often I would perhaps give vaccine dosages, protection for earlier variants will be higher because they share a similar kind of a profile to evoke antibodies against and protection. And therefore, to my mind, it is better not to take the fourth dose unless you belong to highly vulnerable groups, to my mind, not to the youngsters at any point in time, as of now.
So nicely told, sir. I think your wisdom is, or your knowledge part is really, really great to share with us. One small doubt, sir. Actually, when it comes to vaccine, is like told, like our effect of vaccine is waning off over a period of time, and max they are saying it's around.
They have only one endpoint they fix is 6 months. Because beyond 6 months, it would perhaps indicate the best way that it almost drops off. Because unless, no, like it's like India-Pakistan war. No? If there is a ceasefire, would you actually see the soldiers on the border with the guns in their hand? Perhaps not. No, unless there is an exposure, you will not see them. That will become so stark contrast after 6 months. You will find almost everything goes off. But does that mean that the army is not vigilant? Surveillance continues. If it is required, you can mount a stronger response through T cells.
And do you believe, sir, vaccine versus herd immunity? Like we know that maybe after the first and second wave, like most of our country, I think 90% of people might have been infected, maybe a mild or moderate or severe disease. Herd immunity is protecting us, or this is the booster or the vaccines what we have taken is protecting us?
I don't know. I had fought with everybody in the first 6 months when COVID came that I never believed herd immunity exists. Number one. The reason is very simple. A virus which mutates rapidly, an RNA virus can never have herd immunity because escape mutants will be generated which will overcome the protection that is provided by earlier infection or vaccines. There were few individuals who never used to like my statement. Does he understand herd immunity? That kind of criticism also came. But there is another factor that you have to remember. When you talk of herd immunity and you say infection among 70% of people, let's assume 70% was a figure. I used to call it as mirage for the variants. In a new variant comes, the herd immunity level goes ahead. And it says, I am still not achieving herd immunity. One of the things which you have to remember in today's era, the herd immunity as a concept becomes irrelevant for one simple reason that is mobility of people the migration that tends to occur when you have become a global village, you will always ensure that new infection can come in. It can hunt for bodies which do not have the protection, because these are rapidly spreading mutants. They are essentially escape mutants. And therefore, herd immunity as a concept to me is not at all something which we should think about. And that has actually been proven really well. Now, every new variant that comes, you cannot protect an individual, whether he got infection with the earlier variant or even if he was infected, the disease outcomes could be different. But protection from herd immunity against new infection will never occur.
Wrong word, sir. Sir, do you believe whoever has taken vaccine, actually we started taking vaccine and they have also supported the same thing that it will prevent the severity of the disease. Do you believe because we have taken the vaccines, the severity was less? Do you believe in that, sir? I think because you are telling some hard truths, maybe you will be
Not
the best.
hard truths. This is my mind I'm speaking. Now I'm no longer a very active researcher. So I'm entitled to speculations and interpretations my own way. And I'm a free citizen. Now, when we say that it protects you against severe disease, I still believe we do not have any data which says whether it was vaccine that was protecting me or the variant that was produced had less pathogenicity. We still do not know. Or is it a mix? Because there is no attributable fraction that has been derived, which tells you whether this is a mixed effect or an effect of vaccination. Because, vaccine also does one thing, or infection also puts in a pressure, immune pressure on the virus to change. If it leads to certain mutations in genes that are associated with pathogenicity, could be a difference. It is also known that there could be compensatory mutations that may be occurring, which ensure that the balance is tilted towards reduction in severe disease. So today we do not know, if since you asked a pointed question, whether vaccines were protective, I do not know. To be honest, whether virus was changing and therefore it appears vaccines were extremely protective. At least I don't have such a evidence to say that it was only vaccines which were protective. It's like saying that instead of the big cat, as we call as tiger, which was attacking before, and then suddenly you have a small cat, which is a pet household. How do I know? They belong to similar family. I have no idea.
If you have survived a tiger attack, then you will easily survive the attack by a cat, I believe.
I'm just pulling legs, but we don't have data.
Right. One question actually, somebody has asked. I just want after a booster dose, if somebody came positive recently, what is the treatment we advise?
Ideally, if you look at the recent NEJM paper, and if you believe that long COVID is also a dangerous game, the best way is to do is go find out that New England Journal paper. Metformin reduces the risk of hospitalization among patients who come out as positive and attend your OPD. There is a different drug schedule that was actually used in the trial. It reduces the risk of hospitalization, reduces the risk of death, and also reduces the risk of long COVID by 42%. So perhaps to my mind, even if we at least practice use of metformin, which is a very cheap drug, perhaps we may make a difference. We don't know.
Interesting concept, sir. Sir, this long COVID, as you are telling, actually, I was also going through few papers on this post-COVID sequelae or this post-COVID syndromes. Do you believe this is because of the COVID, which is virus, which is still there in the body, is causing the problem, or this is only because of the post-COVID, whatever affected the there are significant report on chronic fatigue syndrome, thromboembolic events, depression. Do you believe this is because of the virus still there in the body, or because of the virus has already exited, but still some effect is going on for a long time?
I would largely believe that it depends on the symptom. Because when you look at symptoms of long COVID, you will suddenly find some symptoms are so mild and some symptoms, which could be mimicked by any condition. जब आप बोलते हैं ना कि कॉग्निटिव उस पे अफेक्ट होता है, अरे
Correct.
व्हाट इज कॉग्निटिव? If you look at your population, they could say, yeah, I am forgetting more often. But what does that mean? Is there a quantifiable scale for the same? Some things can be attributed either due to the psychological impact that that infection may have had. They could be true somatic symptoms that may be occurring. But as I keep on saying, there are certain areas which we have not plugged in science in COVID. We don't have a good definition of COVID beyond duration for which the symptoms survived. Now, duration cannot be a good criteria. So we don't have a good definition of long COVID. Now, whether that long COVID can be associated with viral infection in a definitive or some other end organ is a question of speculation. We don't know whether it would be caused because of that, but knowing that we know Paxlovid can reduce the incidence of post-COVID, when you know that even provision of vaccine reduces the incidence of long COVID, it would also point out to issues related to viruses rather than the immune responses that may be causing it. So, is there a clear understanding on the same? Perhaps not. But I would believe that we should try our best to reduce post-COVID for one simple reason, that I am one who would be worried more about the long-term impact of COVID infection now that we know it was a multisystemic infection. Now that we know it can affect almost all parts of our body and create problems there. Though we don't know fully well what mechanisms it may be adopting, I would perhaps prefer to believe that I need to provide certain medicines which can perhaps reduce the incidence to a larger extent of long COVID. But attribution to only viral factors is difficult to take a stand on, because this virus also evokes autoimmune responses in the body during infection, and perhaps their persistence may also cause, we do not know.
As you rightly told, sir, actually, I was also going through one paper where they have written that vaccines, if somebody has taken vaccine, they're told mostly mRNA vaccines, they have decreased the incidence of post-COVID. And there are few countries who are running post-COVID OPDs also to see these patients having symptom post-COVID for months together. So do you believe we should be having the similar kind of approach to like post-COVID patients, sir? Because we don't have any data from India.
No, we don't have any data, but at least the emerging data is suggesting that the person may develop thrombotic events during post-COVID period. There is sufficient data to talk about increase in incidence of diabetes mellitus. So at least what we know, we should be vigilant about them. If somebody has COVID, though I also know that with Omicron, almost everybody got it. So everybody is perhaps is likely to manifest with one or the other thing over a period of time. So for research, that remains as the biggest challenge. Now, how do I attribute what I'm seeing to COVID infection when everybody, there is no control group,
Correct.
almost no control group.
Correct.
So those challenges will continue to exist. We really do not know. We need to have a, I wouldn't call it as post-COVID OPD, but I would say that every discipline of medicine should be looking at people with a small lens of COVID also as to what is happening and infer based on case-to-case basis.
Something unusual presentation for a case. Even they have told, I believe, like this post-COVID or long COVID syndrome, whatever they like, it may or may not be related to the severity of the disease. Even the patient having a milder disease can have a significant post-COVID syndromes. Like,
Yeah, at least there are some papers which say the more number of COVID infections that you had, the higher is the likelihood of post-COVID.
I think we are diverting too much towards long COVID, sir. So no, actually, I had a presentation because of that. Actually, I've gone through a lot of papers during that time. That to conclude, I think our without like knowing much, the time is like almost more than an hour we have spent in discussing this. What will be your take-home message, sir, when it comes to booster dose? As already you have told, but still, just a take-home message when it comes to for our audiences, let it be our fellow doctors, or maybe to guide them regarding the booster dose when it comes to COVID.
We must remember that this terrorist tends to hunt for the most vulnerables, those who are more than 50 years. I would not even think of 60, more than 50 years of age and with chronic morbidity. Everybody who's beyond that age and with chronic morbidities should consider themselves as a potential target and try to protect themselves with whatever is available. As of now, it's only a precautionary dose that I can advocate. Would even use of mask, no, would it make a big difference? Yes, in a crowded setting, crowded closed setting. But the truth is, you have to ensure that you will continue to wear the mask throughout in that setting. No, even if you use N95, because more often than not, you will find you remove the mask every 5 minutes and take a fresh breath. You have to remember the transmission efficiency of the virus, which is airborne infection. It tends to be high. So they may not remain protective and people will say, "Arey, ye kya bol raha hai karke?" But the reality is they can remain protective, not to 100% levels, but using masks would always be a good thing against this terrorist, which also includes the use of precautionary dose. Because at least you should have the basics of protection in place if you are highly vulnerable. So we should keep on promoting that rather than anything else.
Thank you very much, sir. Dr. Monalisa, like after you have gone through all the vaccines and let's see, as sir told, maybe in very high risk groups, we should think of a booster dose. I don't think we have bivalent vaccines right now available in India. Is it available?
No, they are not able.
So if let's say in India, we will discuss about available
No,
vaccines.
whether you give bivalent or the original one, The
So it will
immunologic
take more.
response is same. It's a original antigenic sin. And the virus is going to generate new escape mutant which will overcome the vaccine protection. So what you have, you should give ideally heterologous vaccine.
Okay.
Ideally. Just in this will give you some. But if you are going to spend, let's say, 1 rupee, you should carry 1.5 rupees in your pocket. No? Something like that.
So if somebody has taken Covishield, should take Covaxin, or Covaxin people should take a Covishield.
Now, ideally, I should not speak because it appears as if I'm spokesperson for somebody. I would prefer either Covovax or Corbevax, but I would rank Corbevax lesser because there is no phase 3 trial data in public domain of Corbevax. But for Covovax, it was earlier called as Novavax. It's a protein subunit vaccine, and there is a phase 3 data that is also reviewed by US FDA, and everything is known about it. And Covax is available in India. So to my mind, that is better than just based on evidences. I have nothing to do with any vaccine manufacturer.
Any take-home message, Dr. Monalisa, before we conclude?
Sir has put everything in place, like we have heard directly from the horse's mouth, like he has been dealing with it. And like the highly vulnerable population should keep their guards high, like using the personal protective equipments, and if possible, can take the precautionary dose and the additional dose if available. That's what.
So,
नहीं, लेकिन मैडम ने अच्छा प्रेजेंट किया बोला वो सारी चीजें उसमें भरे वाली थी.
thank you very much, sir, for sharing all your experiences and expertise. I think for us to think in that level is almost difficult. Actually, we are not dealing with those kind of things. But really, it was honor for me to moderate this session and listen to you. And Dr. Monalisa, the presentation was really good. You have touched each and every person. I believe the people who are watching now and afterward, they will watch this. At least they will have some clarity when and what to use. Sir has clearly told what to use also, which is again maybe a controversy, but as the evidences suggest that is a better vaccine, maybe we should think in that line. At least not for us who are like, even if we are healthcare professional, but not having much of comorbidities, as sir told. If somebody is really vulnerable, more than 50 years, not like 60 or 70, with multiple comorbidities. So in those cases, we can think of a booster dose. That is maybe the take-home message from all what we have discussed today. Thank you very much, sir. Thank you, Monalisa madam. With that, I believe there is no more questions from audiences also. We can conclude the session. Thank you very much. And thank you all the people who have attended the session. Thank you, sir.
Raman, sir. Thank you.